and I will go over sensory to cover that. Then I gave you guys the question, Lippincott question. Make sure you practice every day. When you come back, you check with me the answers. You've got to practice the question. The last page, I gave you some of the drugs which will go with your integumentary system. And keep all your notes together. Make sure you review them and start knowing the best as much as we can learn about the medication. Because in the exam, the drugs are very high. So remember, we must start knowing. I know it is hard, but if you know some drugs would help you for your exam. So I'm going to talk about integumentary system. You do have to write a lot when I will say something, and make sure you add on that. But first page on this one, you guys have the picture of the skin. And we are talking about integumentary. It's the skin care. Skin assessment as a nurse, very important for all of us to know. When you're admitting your patient every day, and when you're discharging your patient, you must assess the skin, because it's very important, the skin assessment. So I will keep talking in between as we move on. But remember, what is in our skin we have? The first thing is the epidermis, the layer. After the epidermis, if you will highlight the word epidermis in the picture, and then you go second layer, after epidermis is dermis. And dermis is more deeper, and then when you go the word subcutaneous, underline the word, and you go tissues, that is more deeper, and you go muscles. When they're giving you any questions, or we are saying patient's skin or burn has been deeper and gone up to subcutaneous and muscles and tissue, that means it's very deep. Everyone is okay? Epidermis is the first layer, dermis is the second layer, and as you deep, you go under the skin. What do we have after the dermis? Subcutaneous. You go more deeper, you have muscles and you have tissue. So if your wound is gone to the tissue and muscles and you're seeing the bone, that means your wound care is very deeper. And same thing when I will talk about the burn. If for degrees of the burn, you got to know the layer of the skin. Everyone must know in the picture. Everyone must know in the decube care, because we must know how to address. When we are assessing a patient, we got to show in the pictures how far the patient's wound is deeper and what are we assessing, and same thing with the burn. So everyone is okay, the layer of the skin, epidermis, dermis. As you go more deeper in the tissue and the muscles, your wound is going to be deeper. Are we clear? So that will be superficial, is always up to dermis. You go deeper in the dermis, we are going more down. Now I will be talking about cancer a little later, but let's go diagnostic test. On diagnostic test, I have first thing is here is the skin biopsy. And I added there the word is, we will talk about that, but I want you to write down the word histopathology. The meaning of histopathology when they're taking out the tissue and we're doing the biopsy. So sometimes the word is histopathology means is you're taking the tissue and you're doing the biopsy. So biopsy is we are taking the tissues, and the word is called histopathology. So it's a good wording, and I want you to add there, histopathology word is for biopsy when you're taking out the tissue. And then I want you to add there, they can use the method of excising. They can excise, they can punch, they can shave the area when they're doing the biopsy. Now, what is it important if your patient is scheduled for biopsy? Number one is consent. Everyone, it's a procedure, is consent. On the first page, you guys have the skin biopsy, and I'm talking about skin biopsy. And I said the word histopathology is important to know when we are doing the tissue biopsy. And they can do by punch method, they can shape, they can go and take out the tissue. What is it important if your patient is scheduled for biopsy? Number one is the consent. We got to get the consent. Number three is very important, is they are going to use local. Local means on that area anesthetizing. That means making it numb. So they're doing the biopsy. In number three, very important line, I like you to highlight the word, what patient would ask you? How would I feel when I'm going for biopsy? Underline the word burning and also stinging sensation, stink sensation, burning sensation. Patient would feel burning and stinging sensation. Remember, we have to let the patient know how do they feel during the test, because we are nurses, we are teaching the patient. I want you to write down after the biopsy, because now patient come back after biopsy. Any biopsy, I want you to write down and add there, what are you monitoring after the biopsy? Is the bleeding, number one. And number two, what do you prevent them? Infection. So two answers are very important. What are we doing after biopsy? You're monitoring, preventing your patient from bleeding and infection. And another thing is, when do you change the dressing? Lot of questions you may see come across in there is you leave the dressing for at least 8 hours. You don't touch the dressing. After 8 hours, you can remove it and you clean it. And remember the sterile technique. Always, you don't want the patient to get infection. And what are we using here? The sterile technique. So everyone is okay about biopsy. Let me repeat the word histopathology. Word is for biopsy. And what do you tell the patient? They will feel burning and sting sensation. What do you monitor after biopsy is infection and bleeding. Those two things are important. And when do you change the dressing? Don't remove the dressing right away. You keep the dressing intact for 8 hours. After 8 hours, you remove the dressing, you clean it. Even sometimes they say patient had a Band-Aid or a dressing. What do you do? Don't touch it for 8 hours. Leave it on. And monitor for infection. So very important, on the first page, everyone should know epidermis, dermis, and under the dermis, I said subcutaneous tissue. As you're going more deeper, you have the tissues and the muscles. And biopsy question, everyone should know these three things are very important. Keeping the dressing intact, monitoring patient for bleeding and infection. Let's move on culture. You are scheduled to do skin culture, just like you're doing a urine culture, sputum culture. Now, when do we do a skin culture? When patient has a wound and there is a drainage and you're going to do a culture. All your culture, underline number one, before antibiotic. Whether it's a skin culture, whether it's a wound culture, whether it's a sputum culture, all the culture, you do not start antibiotic. Doctor has ordered to apply antibiotic. Don't use it, don't give oral until you do the culture. Everyone is okay? Sterile applicator. It comes in the culture tube. They have a culture tube. And you have to open the tube. You have to remove the swab. And then you have to get the culture and put it back. So what do we take it? Underline the word, a sterile culture tube. So make sure it's a sterile. All your cultures, when we are doing, must be a sterile. So what are we taking here? The culture tube. And number three, send the culture immediately. Remember, before your culture, either you put in the cold in the ice, put in the fridge, like a nursing home patients. You don't have the lab there, and they come back to pick it up the next day. And if you collect any wound culture, what do? They have a small refrigerator, maybe for lab, and find out what do you do, because they usually don't come and pick it up right away. So what do? You don't keep it out the cultures, because if you keep it out the culture, the bacteria will grow, and you will not get the right right result. So you got to keep it, or either send it right away to the lab. Everyone is okay on the culture? And then I want you to add there. In that box, you add viral culture word. If there is a question or if there is an order for us to do viral culture, what do you have to do? You send your culture and place them in ice, even by the time you are transporting the culture. Everyone is okay? So write down the word place in ice. If there is a question, there is a bacterial, there is a viral. But if in your question, and if you have a doctor's order for viral culture, what do? You put them in ice when you're sending to the lab. The next thing I want you to add there is another test for the skin. It's called Wood Light. And we must know what is a Wood Light test. So write down the word Wood Light, and what are you viewing? The skin. Underline the word and say you're checking the skin under, I wrote it down here, under what? Ultraviolet light. And the room is dark. So what is a wood light is? You're examining the skin under ultraviolet light, and the room is going to be dark, and they're using a special glass, and the glass is called Wood's glass. So what are we using here? Wood's glass. And the room is dark. And what are they using? Ultraviolet light. And what are we examining? The skin. So what is a wood light? You can remember the word. The skin is viewed. Viewed means you're looking the skin under the microscope and under ultraviolet light. And what are we using here? The wood glass. So what are they using here? The wood glass, ultraviolet light, and they're checking the skin to see the kind of patient has infection. And it's a special glass, and it's called wood glass. Remember the word, two word is important. Wood glass, and second word ultraviolet, and third word the dark room. And what would you do? Sometimes there are questions if you're going to do Saunders question, and you do have in skin integumentary system the question that what do you do when you're examining the skin, and after the wood light test, what would you do, because the patient was in a dark room. So it's safety question. Assist the patient to adjust in the light. So because you're coming out from the dark room, and what happened when you're in the dark room, you can see very well. So your answer is, what do you do when the wood light test is done? Assist the patient to adjust with the brighter light. That means you know the patient is coming out from the dark room. Everyone is okay? The wood light test. Now, so we are done. Some of the things I like to add here, and the skin culture, and I said the skin culture, very important, the viral culture. How do you send the viral culture? Is in the ice. You must know how to do culture. Every day we are nurses. You have a wound care, and doctor will order the viral culture. So there are tubing, and you got to get the culture tube, and you open the wound dressing, clean it and go deeper and get the culture, and you put the tube in the culture tube, and they have a little space. You have to break that because then it has a chemicals, it keeps it moist. Everyone is okay? And when do you do the culture? Before you start antibiotic. What do you do if you have a question on viral culture? You send it with what? In the ice. Everyone is all right? The wood light, we talked about it. I'm going to go on the second box on there is skin testing. What is a skin testing is when you are checking for allergies. So what is skin testing? We are checking for allergies. Underline the word, what do they give in allergy test is underline the word allergen. So what are you introducing under the skin? Underline the word allergen to the skin, into under the skin or into the dermis. So what are we injecting? Allergen. Everyone should know in allergy test what are we using? Allergen. Then we go on second line. I was talking about how they can do by patch, the skin testing, a scratch, or intradermal. Now you guys, we all know is PPD. How do we do the PPD for TB? We go intradermal. dermal. Remember that? That's a skin testing. That's a testing for allergies for TB when we are doing. So any test is done to find out the allergy is called skin testing. Where do you give? Under the skin or in intradermal area. The third line, very important, everyone should know. When your patient is scheduled for skin testing for allergies, remember, you are not giving medication, underline the word, steroids, corticosteroids, or antihistamine for 2 days before the test. So what do we hold here? For 2 days before the test, we are holding is steroids, antihistamine. That's important. If your patient calls and says, I am coming, but I already took my steroids, I'm on steroids and antihistamine, but I'm scheduled for test this morning, what would you do? You can't do the test. You have to tell the patient you will be rescheduled for the test. Everyone is okay? You have to reschedule the test. So what do you hold for skin testing? Steroids, antihistamine for how long? 48 hours. That's important. Consent is important. And what can happen when you're giving allergy test is anaphylactic reaction. Underline that word. Any question, anytime you're looking at a patient and patient has allergy, what are we monitoring the first thing? Anaphylactic reaction. Are we clear? What is an anaphylactic reaction? You will monitor, number one, airway. That's important. Don't pick up rashes and other. So it's important. Be prepared if patient has to be needed any special attention. Now I will go, now third box it shows about the allergy, so you don't need to know too much on that. But yes, a skin culture, very important, and patient is scheduled for allergy test. Remember, you're holding steroids, antihistamine for 48 hours. That's important. Fourth paragraph, it doesn't say much here, but I want you to add there are herpes type 1, herpes type 2. So I wrote it down here. Herpes type 1 is cold sore. That's type 1. It's called cold sore. And where do you see? On mouth, lips, and nose. So whereas type 1 is mostly they're like a cold sore, and you will see it on, we have it here, you guys can add it there on the lips and to the mouth, and they are very small. It's about 0.5 centimeter. So we are talking about herpes. Herpes are two. Number one, type 1, which is cold sore, and is mostly on the mouth, lips, and nose. The lesions are very small, around 0.5 centimeter. And they are febrile. They may have fever. Febrile means the fever. Self-limiting. It goes itself and it will be back again. So that is type 1. Type 2 is genital herpes. And genital herpes are mostly on cervix, you can add there, and penis. And what are those are? These vesicle, they have vesicle word, so maybe you guys can add the word vesicle, and then they rupture. And when they rupture, they cause ulceration. So I want you to write down the word ulceration. So these are the vesicles, genital herpes, and they start with flu-like symptom. And they have flu-like symptom, and also I said here, underneath, I added herpes are more viral infection. How do you treat them? I added the medication is Zovirax and Asclovir. Now, how do you give them? I wrote it on the top, maybe oral, maybe IV, maybe local. Local or topical means to the area you can apply. And so inhibiting, and any questions on Zovirax it's a viral medication. It doesn't cure, but what does it do? Lot of question on your medication. It inhibits viral reproduction. So what is it inhibiting? Viral reproduction. So I want everyone must know the herpes. You don't have much here. but you guys must know type 1 is cold sores, and you have on the mouth, nose, and maybe on the lips. The lesions are very small. Genital herpes is on the cervix and on the penis, and it causes the vesicle and they rupture, and then they can cause ulceration. Medication, very important. You guys write down the medication is Zovorex, and you can give them is by oral, can be given IV and topical. Topical word you're applying on the skin, and what does it do? Remember the answer, inhibit viral reproduction. We all must know it's inhibiting viral reproduction. Page number 3, you guys have picture on Koplik spots. I want you to add there, this Koplik spot is a sign of measles. So add there measles. And where do they have Koplik spot? Inside the mouth. They have the red and the white pimples or the sores in the mouth, and that is the sign of measles. And that is in the measles Koplik spot. Now I will take this off. Everyone make sure you guys add the word Zovorex, and you already added the word histopathology for tissue, and I want you to write down the word woodlight. Everyone should know because those are important. You do have in your books, so we must know something. Now on page number 3, I will be talking about the pressure ulcer. Now we all know pressure ulcer, and what is the reason for pressure ulcer? What are the reasons for pressure ulcer we have? Anybody? What are the reasons for your pressure ulcer? Why do the patient has the ulcers?
They don't reposition.
We're not repositioning, number 1, which is correct. What else? What else is?
Malnutrition.
Malnutrition. I will be talking, very good. And that's number 1. So you guys have this picture here on pressure ulcers, and what is in the pressure ulcer pictures are, number 1 word is sharing. What is the word sharing? If you look in that picture, is sharing. Now when does this sharing comes? When does this sharing come? Can we prevent sharing of our skin on our patients? Yes. You leave the patient sitting in the bed after patient finish eating their breakfast, and you leave it for 4 or 5 hours. What happened? Patients start sliding it down. What happened in the wheelchair? Patient gets tired, they're sliding. So what is sharing is rubbing of the skin. Patient's skin is rubbing because of what? Our nursing care. So very important, the word is sharing, and you prevent sharing. So what do you do after your patient finish eating? Roll them back, let them lay back on their back. Don't leave them sitting too long. If they're sitting in a wheelchair and they're sliding, that is going to cause the skin breakdown. No matter what, how healthy skin is, but what are we doing? Causing is shearing. So I want you to write down is, if you move on a little bit on page 4, you guys have more prevention. So I want you to add, and then I will go back on page 3. So let's go in prevention of pressure ulcer is number 1, is we said sharing. But before that, I want, very important, is malnutrition. Everyone. That's number 1 reason for your patient to get is the bed sores. Food, they're not eating. Their skins are not healthy. So number 1 is prevention of pressure ulcer. We must know the reason for pressure ulcer. So write down the word risk on the top, and then you have prevention on page number 4. What are the risks for your patient to get the bed sore? Number 1, malnutrition. Then I want, number 2 is, I will leave the word sharing, and I will say the other word is incontinency. Your patient are incontinent, and we are not changing them, then what happened? What happened to the patients who are incontinent? Or they're going to have skin breakdown because it's the moisture, the wet they are. So you must change your patients regularly. Then we said turning. Here someone said here turning, and that means is what? Immobility. Patient which patient are you going to turn? The patient who cannot turn themselves. Immobility. See the correct wording, we got to go. Malnutrition, incontinent, and immobility. Sharing, we already said. And very important, decreased sensory perception. What is the meaning sensory perception? They have no sensation, no feeling of pain. Are we clear? Now, if me and you will sit and we don't turn, we will know the pain and we'll say, oh, I want to change my position. I can't sit that long. But what happened to a patient who does not have a sensory perception? The meaning is they cannot feel any pain. And that is what patients are like diabetic. Remember the word neuropathy is lack of sensation. So very important that we all know. Number one, whether you are turning incontinency, if you got to pick up, the first answer is malnutrition. Everyone is okay? Malnutrition is important. Even you turn a patient who's not eating, even you buy an expensive bed to put that patient to prevent sore, but if patient is not eating, you are still not going to prevent the bed sore. So very important is the nutrition, and yes, you keep them clean and dry. Patient who's immobile, we got to turn them frequently. How do we turn them? Not only in the bed. Remember, is when you are turning your patient, immobile patient, is in the bed, they can turn. Yes, you are turning them and turn them as frequently every 2 hours. But if they give you a question, patient is mobile and patient is in a wheelchair bound and patient has a redness, what do you do for that patient? What do? Don't put them in bed and turn them. They can change the position in the wheelchair. And what do you tell them is change the position, shift them from every 2 hours or 1 hour. If you have a patient who's going out all day in a daycare program, do you want to lay that patient because of the redness and lay in bed and turn them? Your answer would be wrong. You want patient to continue going out, and your question is saying patient is what? Is immobile, but patient is wheelchair bound. Patient is wheelchair bound. Patient is going out in the wheelchair. What do you teach the patient? Turn the position. So remember, not only turning in the bed, but the wheelchair, anybody, even you're sitting in a chair, you move around a little bit and it makes a difference to change the pressure. Everyone is okay? And malnutrition, incontinency is important, immobility, sensory perception, and malnutrition. In your question, yes, if patient has a sore, you may need a special bed, or high-risk patient. How do you prevent the skin breakdown for your patient? Number one, all your patient you must assess every day or on admission. Are we clear? If you assess your patient, what are you going to do? You're going to make your care plan, nursing planning. And what is your nursing planning? You already know this patient is a risk. In NCLEX exam or as a nurse, they're asking you, what would you do if you're working as a nurse? So what do? We assess a patient. Patient came in, I already know this patient is overweight, this patient is immobile, this patient is incontinent, and this patient is diabetic. Wouldn't I think I need to prevent the sore? Are you waiting to have a sore or you want to prevent the sore? So remember, what are we doing here? Prevention. All your questions are going to be for assessment. You assess your patient, find out the risk factor. What are the risk factors for your patient, and you prevent the sore. So you look these risk factors. Patient who cannot turn themselves, patient has less sensory perception, the diagnosis, and patient is not eating, they're number one, risk for sore. Let's go on prevention. You guys have a box on page number 4, prevention, cleaning. Yes, keep the skin clean is important. And number 2, moisturizing. Moisturizing by using maybe A&D and maybe a lotion, maybe a moisturizer barrier. And sliding patient, lifting rather than sliding. Whenever you are moving your patient, lifting is best. And why sliding? Because it causes the friction. Friction can cause the skin breakdown. Avoid keeping the patient's head of the bed very high because they will slide. So, and it causes pressure. Turning is very important. Use the pillow and use as the doctor has ordered. A lot of doctors are not using these days the donut. If you remember, there was a round donut we used to use a lot of on the wheelchair, and they have been cutting down because there are a lot of better products are there to prevent the sores. You have a special gel wheelchair cushion, and that gives equalized pressure. So I would say any preventively the doctor has ordered for wheelchair, the bed, a special mattress to go, airflow mattress, you may have Acrylic mattress, and they have been coming up with a nice Acrylic mattress which is already covered. Otherwise what happened? You have an incontinent patient and they pee and the urine goes and Acrylic mattress get really bad. So they've been coming up with the better ones are and better air mattresses, air flowing mattresses. Buildings are hospitals, they buy their own, they don't have to order to cut down the cost. We used to have very special and expensive beds to order, but it cost a lot of money. But now everyone has their own mattresses and use the good mattresses. Use the soft padding for your patient. Why? The hard bed is going to be very hard for them and the skin breakdown. So that covers up here. Now let me go back on the pressure ulcer. What is the pressure ulcer? On same page you have the stages. What is the first stage you will say? Now we must know in the pressure ulcer the stages. Stage 1, stage 2, stage 3 and stage 4. There are 4 stages. What is stage 1? What is the stage 1 is when the skin is intact. Remember the word, a skin is not open. There is a redness. That is your stage 1. Everyone should know the stages. Everyone should know how to recognize in the picture because you can get in the exam is the pictures of the pressure sore. And when you are monitoring your patient, so write down stage 1, skin is intact. Intact means is not open. And also, stage 2 is stage 2 when it starts opening but is partial. It's open partially, very small area of the skin. And thickness is in the stage 2 is partial thickness. And epidermis and dermis. So write down here, the epidermis is open and dermis is underneath, you can see it. It could be also superficial and it can be a blister. If they give you the wording blister and blister is open, that will go in stage 2. And blister is open because you can see the skin. Outer skin is open, epidermis is open, and you can see the dermis. Maybe a little deeper, that's a stage 2. What is stage 3? Would be more deeper. So we must remember stage 1, the skin is not open, redness is there. That redness doesn't disappear, that is there. That means patient is starting the skin problem and you got to prevent them. That's the beginning. Now you have stage 2. Stage 2 is open epidermis and dermis. Blister can be in stage 2. Stage 3, you will go full thickness with dermis. So dermis is there, a little bit more thickness. It has more thickness of the skin is gone. And you have dermis, remember the word. And also write down the word subcutaneous tissue. What do we have here? It is subcutaneous tissue. So the subcutaneous tissue is there, and then you will go, maybe there is a slough. What is the word sloughing? S-L-O-U-G-H. When you see the yellow part and the wound is covered with the slough, you got to remove them. There may be a drainage word. That means your wound is draining, maybe. And the wound is going a little deeper. And remember, when we say the word purulent, what is the word purulent? Is bad, infection. Purulent means a pus. And next is maybe tunneling. The word is, everyone should know, tunnel. Tunneling. What is the meaning? Tunneling we use in the wound. When you're going in the wound and you take a Q-tips and you're going in the wound, it's not going very deep, but yes, dermis is gone and it start making around the wound. So you're not going like this, and if you go around the wound, all the tissues are getting bad. Everyone is okay. Tunneling is around the wound, the areas are. So when you will be doing the wound care and you will be documenting, so remember, if your patient, always look through how far the wound, not only going like this deeper, but you are putting the Q-tips and seeing, is there any tunneling? The surrounding tissues are bad. Stage 4. Stage 4 is more deeper. And stage 4 goes to dermis. You will go full thickness and muscle and bone. You are seeing muscle and bone. There may be a drainage. There may be undermining tunnel. We use the word undermining tunnel. So you have the tunnel, you have the drainage, there may be slough. But what is it important is going to the muscle and to the bone is much deeper. That means the wound has gone very deep. And I'll tell you, everyone should recognize the pictures because you can get an exam, anything. We all need to know how do you identify. When we are working, we have a picture in the documentation. You've got to show how is your wound care is looking. Very important. Every week we must document the wound because how do you protect yourself in wound care? By documentation. So everyone is okay, the wound care. And I want you to remember on the third one on the box here is you are checking on the skin. Not only one thing. I'm going on a little bit. We talked about the wound, prevention of wound, but we are nurses. Your patient comes in. You are admitting your patient. And what do you do on your patient assessment? Very important is what? Your skin assessment, or remember the word integumentary. You have a whole picture. You got to complete. What do you document in integumentary system? Yes, we will document redness, pressure, sore, we all know. What else would you document on the skin? What do we document on the skin? How about the bruises? Are you going to document? Yes. How about the skin tear? Are you going to document? Yes, very important. When you're working and you have a patient and that patient start having 4 or 5 bruises, and we're going to answer where these bruises are coming. And if you don't document, you go home, they're going to call you and find out, when did you notice the bruising on your patient? Because it's a sign of abuse. Everyone is okay? So what do you document on your patient? And if they say, you have a patient who has a lot of bruising, are you going to assess that? Yes. Are you going to assess the skin tear? Yes. You got to document. You got to get the doctor's order. Yes, any redness, any open area, everything you document on your notes when you are assessing your patient. You walk in, your CNA comes or UAP comes and tells you, I have a patient who has bruising on the face or on the hand. What do? You must assess it, you must document it, notify family member. You think family member comes in and they see the bruising, aren't they going to question us? Yes, so it's very important we document all that. So remember, a skin assessment. How often do we do skin assessment? How often would you assess your patient's skin? Every day, every shift. But what is the important time to assess whole body? During their shower, during their bath time, we must assess and we must document. And what else we are assessing in the third box? Edema. Other patients are high risk who has edema for the skin breakdown. Yes, because why? The skin is stretching with edema. Patient who has a lot of edema, there would be risk for skin breakdown. Plus, you're monitoring what is the word would call and what would be your nursing care plan if your patient has edema and patient is retaining fluid. What would be your nursing care plan? What is the nursing care plan for your dehydration? We all should know. We are nurses, we got to write the care plan, and you're going to see the question in exam. What is the edema means? They're retaining fluid. What is overload of what? Fluid. Related to CHF. Related to what? Renal failure. So what is edema means? Overhydration. Over fluid retention. Everyone should know. Dehydration. Fluid deficit word. We must know the care planning. You are going to get the question on care plan. You got to know what is your care plan for dehydration would be. What is dehydration? Is when patient is losing a lot of fluid. So you have fluid deficit. When you have over fluid, are we assessing the skin for dehydration? Yes. Are we assessing the skin for patient with edema? Yes. And what happened with dehydration? Dry mucous membrane. Remember the word? And also you are checking the color of the skin and you are assessing your patient. So remember, is how best size for assessment. You assess the skin. Don't forget we are nurses for edema. You're checking the skin for dehydration. What are the symptoms for dehydration? You will monitor. You can look at the skin, you can look at the vital sign, and what happened when patient is dehydration. Very important these days in your questions is they're going in what? Hypovolemic shock. Remember? So dehydration symptoms are hypovolemic shock. And what are the hypovolemic shock are? What is the sign of shock are? The blood pressure is what? Going down and pulses going up. So you may not have all the symptoms. They're not going to use the word shock, but they're going to say what? Tachycardia word. And the skin is dry. Eyes are sunken. In the fontanelles in the babies are depressed. Remember? And what do you monitor? Turgor of the skin. You've got to remember what you have done in term 1. That is your basic nursing. And that is what they're looking in exam. And we are practicing every day for our patients. So remember the dehydration question. Let me go back now on page 3. I skipped that. I wanted to talk about that. In pressure ulcer, let's go on page 3 and the box where it says transparent dressing. You have a patient and transparent dressing, you can use it. And where do we use transparent dressing? If you have IV. So IV site, they put the transparent dressing. If you have TPN or you have central line, they can use the transparent dressing. If you have a very acute and small skin open, a stage 1, they can use it, the transparent dressing. So what kind of dressing we are using for IV, for central line, for TPN? You are using the transparent dressing. Transparent dressing you can see through and you can use for the superficial and acute wounds. Are we clear? Now wet to dry dressing. What is a wet to dry dressing is, we all know why do we use wet to dry dressing? To debride the wounds. So make sure we underline under wet to dry dressing, it says the word debridement. When we are doing wet to dry dressing, what are you using? Normal saline. There is wet to wet dressing, there is wet to dry dressing, so I want you to write down you wet to wet and wet to dry. There are two wording, you have wet to dry. What are we using wet to dry? To remove the dead tissue. And the word is called debridement. What kind of debridement is called, I want you to add the word, is called mechanical debridement. So what is wet to wet dressing, wet to dry dressing is mechanical debridement. That is a wording, and we all should know mechanical debridement. There is also, what are the kinds of debridement we have? Number one, mechanical, and number two, I want you to add there chemical. What is chemical? When you're using ointment. There are small ointment we have, and if the wound is smaller and is necrotic, we can put the ointment, is called chemical debridement. The third thing on debridement is surgical debridement. What is surgical means that by removing, by surgery, and doctor is taking a scissor and they're removing, scraping, and they're removing the dead tissue. So everyone should know what are the types of debridement we have. In your question, wet to dry dressing, what kind of debridement? They can ask you, is mechanical debridement. What is a chemical debridement? You're using ointment. What is a surgical treatment? When you're removing by surgery. Now, burn patient, we use hydrotherapy. What is hydro means? You're putting them in the water. And water therapy softens the skin and it helps them in debridement. And what are we using in debridement and the wound care? Normal saline is the best. What is wet to wet dressing? When do we use wet to wet dressing? When you're healing of the wound. Your wound is healing and it's giving them the moisture. So what are we giving here? Moisturizing the wound and keeping it moisture and keeping it clean wound. So this wound care is done wet to wet, your deeper wound, you keep it moisture and that help them to clean as well as to heal the wound. So there are wet to wet dressing, there is a wet to dry dressings are there. Now I want to write down two wording here, which is important for your exam, and as the nurses, we all should know the wording of the wound drainage. Purulent means is pus, we all know. Purulent means is the pus, but I want you to write down the word is sanguineous, S-A-N-G-U-I-N-E-O-U-S. Sanguineous is not. Patient come back after surgery and you are changing a dressing. And the drainage is sanguineous, means is bright red. They didn't tell you what color, but they said patient has this drainage, means bright red. And what is the meaning bright red? Patient is bleeding. You got to notify because patient is bleeding. Number two is serous anguinus, S-E-R-O-S-A-N-G-U-I-N-E-O-U-S. Serous anguinus has pale color, red, watery, like a color, and this is normal. And so pale red watery color is because, why? Because it has a serous drainage. And this is normal. That is mixed with the red and pale and watery serous anguinus. They look about the same. This is much longer, but sanguinous means is the bright red. Any wound care, patient come back, patient has sanguinous drainage, you got to notify. They will throw. They might throw some other wording, but remember, if you have this wording, that means the patient is bleeding. What is the word purulent is infection. You got to notify if you see the word purulent. So we must know the wound care, you must know your assessment on wound care, and you must know documenting the wound care. Now I will move on page 4 on skin cancer and talking about the cancer. You may get the pictures on cancer, and you have, it says the skin cancer, and the causes of cancer are on skin exposure to sunlight, underline the word, or ultraviolet light. And the bad time to be out in sun for too long, 10 a.m. to 3 p.m. So what are the reasons for skin cancer? Exposure to sun and ultraviolet light. That's the time. Number 2, chemicals. Number 3, friction. And number 4, receding hairline. That can lead to cancer. I will move on to the next page, and I would like to write down the word 3 type of cancer. On page number 5, let's move on page number 5. You have assessment, and you have the word in the first box, the normal, mole, and melanoma. Melanoma are a skin cancer, but there are 2 wording, and I want you to know those wording and write down on the top. You do have basal cell carcinoma, and number 2, you have squamous, S-Q-U-A-M-O-U-S, squamous cell carcinoma. And third one is the one you have, is the word is called melanoma. Okay, so basal cell are, the first one comes from sun and chemical, and it comes from, as the word is, it comes from basal cell in epidermis. So if you have basal cell, that comes from basal cells in epidermis, and they're mostly on the face and the upper extremity. Basal cell carcinoma. They don't rarely metastasize. They don't metastasize, they don't spread. Squamous cells carcinoma, they are also coming from epidermis, and they can metastasize to lymphatic. So write down the word they can. And they can metastasize through the lymphatic. But melanoma are the main cancer you have. And when we are saying basal cell, I said there is on the basal cell are mostly on the face and the trunk. Now this one you have is top, they are the second one, they are little crusty, but they are also the kind of cells you have coming from epidermis, and also they can spread. But how do they spread? By lymphatic. Now everyone, I want, you guys have your adult health nursing. You will not find pictures anywhere in your example, but you must look. And I will show you, I have taken out, these are from adult health book, and keloids. Everyone should know these are the keloids, those are surgical mask, scarring. Keloids are what? Mostly in the skin after surgery, and they form the keloids. These are keloids. The one is on the nose, we have here is the basal cell. And this is the one more rounded, look more ulcers, and I will pass it and then you guys can see it, but I will advise you whenever you're going for your exam, you must look all your wound care question, because we are nurses, you can get all these pictures. Now this is the one is mostly on the face and there. Now this is squamous cell, it has a crust on the top, that is the squamous one. But what is the melanoma? I will show you here is melanoma, these are the one. And you can see the difference between all of them are the color. And you will see how the darker they look and how spreading all over. And these are the ones are the skin cancers. and they can throw those pictures for us in the exam. So I want us to look and recognize the picture. So let's go back on now page number 5. So we already said there are basal cells from epidermis, squamous cells comes from epidermis, and they can spread to lymphatic, but the melanoma are the main skin cancer. So let's go on melanoma. And it says the word here, melanoma, and it says normal mole they're showing, and melanoma, and go in the third box, it says asymmetry. Asymmetry means unlike the others. They don't look alike, and they're unlike the others. So you can say what is asymmetry are. When you're looking them, they don't look alike. Then second thing is in the picture, you guys have the border. What are the borders are? You can write down there, irregular. So if you're looking on the side, they're irregular, you must know. And number 3, you will go color. The colors are darker and the colors varied. So you got to look for colors. And diameter, the last one I want you to add there, they can be bigger than as 6 mm, 6 mm diameter. So these are the pictures are on melanoma. Melanoma are different asymmetry word, you must know. Border are irregular. Colors can be varied, can be black, can be brown, and can be tan. And the diameter, I want you to add there, larger than 6 mm. So everyone is okay about the cancers we are talking, which is the main cancer of the skin is melanoma. Are we clear? The second one, squamous, they can also spread, but more lymphatic. Okay, so we talked about on page number 5, everyone, make sure we open page number 5, and we said, well, how do you recognize, make sure we know the pictures, and we are looking at the pictures, and now I will move on page number 5, nursing intervention. What is nursing intervention and teaching here? Avoid going out in the sun 10 a.m. and 3 p.m. Those are the time. And monitor any lesion on the skin. Number 5, any lesion does not heal that may be or change or that changes the characteristic. You should pay attention, find out what's going on. Number 4, number 3, avoid contact with the chemicals. Number 4, sun lotion and sunscreening lotion when we are going out. Protect the skin from sun. And number 5, surgery may be required for the lesion or the testing. So everyone, we talked about a little bit on the skin cancer, and what is the main skin cancer we called is the melanoma. And we talked about the melanoma. I will move on about the word on page number 5, dermatitis. When we get the question, dermatitis, what is the meaning? Dermatitis is coming from any kind of allergies. And go under, it says caused. How does it cause? Underline the word contact with antigen. Underline the word antigen. Maybe poisonous thing, poison oak. Maybe any fabric. Maybe cosmetic. Maybe any detergent. Maybe any kind of soap we changed it. Or any kinds of paints, dye, the rubber compound. Anything can be caused the dermatitis. And what is the word is very important, when the body come in contact with antigen. Are we clear? So what is the word here? Antigen. What do you assess your patient with dermatitis? Number 1, pruritus is itching and burning. There's a burning sensation. Number 2, edema. And number 3, erythema, redness. Number 4 and 5 is important. What do you prevent your patient with dermatitis or infection? Why? Because we are itching and skin opens and lead to infection. What do you prevent patient with dermatitis? Prevent them from infection. That's your answer. What do we prevent them? Itching. Pruritus. What do you do for your patient for itching? Is number 1, the nails. Patient nails should be trimmed. What happened? You scratch and your skin will open it up. Maybe covering the hand, maybe a mitten, maybe a socks, maybe a restraint in the baby. And what kind of babies in the restraint you use it is the elbow restraint, right? And maybe a adult person now, you don't want to restrain because in the wrist restraint, hand restraint, the wrists are more fractured. Maybe you can come up with a nice, is the hand mitten and nice looking socks they can wear and cut down. And you give them the itching medication. So I'm going to move on implementation. So when we see the word dermatitis, dermatitis means one word, remember antigen, second word, remember for your exam, preventing patient from infection. Second box, you will go elevate. Anytime you have edema, we can elevate the area. Number 2, cold, wet dressing. So what kind of a sponge you are using or you are applying? Cold, very important, cold word. Cold environment. Protect the patient from scratching is important. Next page, number 6. Instruct the client for contact with the allergies. And next is about the soap. If there is allergies from detergent, from soap, you got to change it. Avoid itching, use of astringent. Whatever the reason itching is, avoid that. You know why and what is the reason. Avoid heating pad and blanket. So cold is good. No heating pad, no blanket. And medication are, number 1, antibiotic. If they have infection, you can give them antibiotic. Itching medication, antipruritic medication. What is antipruritic medication do we have? Anybody has come in contact with medication with itching you can give them? What are the medication are? Hydrocortisone. Hydrocortisone is steroids. Your itching medication can be your Benadryl, right? And Atarax. Atarax you can give them. So itching medication, Benadryl, Atarax you have, they can use it. So doctor would order the medication for itching and you use it. And also what can be given them? Antihistamine. Benadryl is also antihistamine. Steroids are given for inflammation. Whenever you have inflammation, you're using the steroids. Everyone should know why do we give steroids to reduce inflammation. Everyone is all right? And that we are using. So dermatitis, we talked about it. Now I'm going to move on cellulitis. Cellulitis is going not only epidermis, underline the word, is going deeper. And how far is going? Into the dermis. And what is the reason here is Streptococcus pyogenes. I'll tell you in NCLEX exam, we must start knowing the wording of your infection and the germs. Are we clear? So underline the word Streptococcus pyogenes can cause infection and is going, very important, to dermis and subcutaneous fat. That means it's quite deeper, infection is. And use, next line, underline the word medication, darkened solution, which is called sodium hydrochloride. And what is this darkened solution is to use for flushing the pus exudate. Use only for irrigation. Underline the word in the last line, not for packing. So what are we using this solution? Only for irrigation. What is the meaning irrigation? Washing out. But do not use for packing, because we do use a lot of things for packing of the wound, but not the darkened solution. Assessment. What would you see in cellulitis are assessment, pain, itching, swelling. Number 3, very important. I have seen a patient who came back after surgery, had a hip surgery on the right hip. And you can see the difference between the left and the right thigh. His thigh was so big. and red, and it looked inflamed. And why? Because patient had infection, not it happened with us, came from surgery, had infection. And what does it lead to? Infection went to the deeper, to the dermis. So very important, very clearly, you see a patient who's having changes and looks different. So very important is swelling. Very important, number 4, is red and warm to touch. So very important 2 words, swelling, redness, and warmth. Then we go implementation. Immediately you find a patient who has cellulitis and you see there is a redness, there is a swelling, you got to notify the physician. And what do we do? Rest. Number 1, it's a bad infection, provide rest. And number 2 is now you can go warm compress. There is inflammation, so highlight the word is warm compress to decrease edema and erythema. Number 3, very important, is antibiotic. And when do you start antibiotic? After the culture. So what do we do? There's maybe a drainage. There may be open area. If there is no drainage, then they can do the blood culture. Everyone is okay? So what do we do? Culture. Why do we do culture? So you can give a proper antibiotic to your patient. So we got to do the culture. So we are doing culture, and then patient would start antibiotic. And mostly they will start, it's a bad and deep infection, IV antibiotic. Not locally, not orally, because the infection is really bad, IV. And keep the skin area clean, and antimicrobial soaps to clean the area, or maybe if there is an open wound there, you're doing the dressing, but keeping the area clean. So everyone, cellulitis, I would ask you to remember the word is deeper in the dermis and subcutaneous. And it's infection, and you can use the solution, and in your drug, in your skin question, darkened solution is only used for irrigation. Then we moved on, there is a swelling, there is a redness. And what can you apply here? Number 1, patient is resting, you got to do the culture, and we got to apply the warm compress and monitor for the temperature and infection. Now I will move on page number 6 is the 4th box, and it says hypothermia. What is the meaning hypothermia? Hypo means very cold. And if with the effect of cold, now skin can be damaged. A very extremely cold temperature, and a lot of patients can get, and we call the word chilblains. Underneath you have the word chilblains. And that is ulcer, like they feel ulcer, and the fingers, they feel very sore, and because of the cold temperature. Another word is called frostbite, like frozen. Frostbite is a frozen extremity. You have some question on your Saunders book on frostbite. Are we clear? So I want you to, it says avoid cold temperature, smoking is good, but I want you to write down is the treatment. And what does the patient feel when they have frostbite and chilblains? Number 1, numbness. They feel very numb, and they feel paresthesia. Paresthesia they feel, and also it can cause necrosis. Keep it in mind, chilblains and frostbite can lead to necrosis and can lead to gangrene. What do you do in your question are rewarm. Rewarm, your answer would be the affected area. You have to rewarm the affected area, and you're warming, that means you're bathing the area with the water temperature 90 degree to 107 degree Fahrenheit. Until how long you will keep it? Until a skin is flushing. Until the skin is flushing. So your answer for frostbite, what are you monitoring? Paresthesia. What are you monitoring? Patient necrosis. And what do? Your answer would be rewarm the area. That means you're putting in a warm water and not you're doing slowly. You got to put them. And your answer would be 90 to 107 degree Fahrenheit and until the skin is flushing. Do not pick up the answer is avoid slow thawing. The word is thawing. So avoid in your answers, the word is called slow thawing. Like you take out the meat from the freezer and you keep it out. That's a thawing word. So what do you avoid? Slow thawing. Thawing. Why? Because it can cause damage the tissue. So don't do slow thawing because it causes the tissue damage. So your answer would be patient is frostbite. What would you do? Your answer would be is rewarming the affected area in the temperature with 90 to 107, and they may have answered thawing, no. Putting in cold, no. What do? Rewarm the affected area. And what is the problem here? It leading to necrosis and leading into what? Gangrene. So you got to be careful. Pain medication you can give them and handle your patient very carefully. And yes, smoking is good for circulation. Avoid the cold temperature. I will move on to the next page, but let's take a break. So we'll take a break and then we'll come back on page 7.